Hello, my name is Jen James. I'm from the University of California, San Francisco, Center for Aging and Diverse Communities, and I'm excited to share this work with you today. I want to start by telling you a bit about a woman I had the pleasure of speaking with for this project. She asked me to call her Fox. Fox is a 52-year-old Black woman. She's a woman of faith and credits surrendering to the Lord as a turning point in her life. She was serving a sentence of life without the possibility of parole, and she'd accepted that she was going to die in prison. While she was there, she became a leader in the community. The officers and wardens would seek her out, asking her to do community outreach and lead education efforts, and she felt like she became a respected figure inside. Fox endured unspeakable trauma and abuse when she was growing up, and yet she told me she never knew that childhood factors and circumstances shaped who you are and how you made decisions. She learned this after being in prison for 15 years. Before that, she thought she was just programmed to be bad, that she was just born bad. Fox experienced the onset of chronic and debilitating back pain while she was incarcerated, something that's quite common. And she told me, describing when this started, she was cleaning the visiting room in the prison. She said, "I tried to stand up and I hit the floor. I hit the floor and I started crying and crawling. They took me to medical and it was like, nothing's wrong with you." And I'm like, "Really? I peed on myself. I can't move. Nothing's wrong with you. Nothing's wrong with you." So for months, she asked for help and complained of pain. And she told me finally, a doctor said, quote, "I'm going to order you an MRI so you can stop coming here and complaining." She said, "I just see you keep coming here talking about your back. Well, we're not going to give you narcotics." And Fox told me they assume that the patients are drug seeking and noted that some patients are. So when she finally got her MRI on a portable machine that was brought into the prison on a diesel truck, which I didn't know is how MRIs could be done, she remembered being slid into the machine and being able to hear the technicians talking through the speakers. And she said, quote, "I heard one saying, 'It's a wonder she could walk.' Tears just started rolling down my eyes. I just wanted the validation. Okay, something is wrong." So finally, after a year of pain, she was able to start getting care. In this presentation, I'm going to use the stories of Fox and other women I had the pleasure of interviewing to describe if and how Black women were able to access healthcare behind bars and the implications of the barriers to accessing quality care, the implications of that on the health and aging for Black women behind and beyond the prison walls. So I'll start with some background. The incarceration rate has exploded over the last 50 years. It's increased more than fivefold since 1975, and actually the number of incarcerated women has grown eightfold since 1980. There's more than 200,000 women incarcerated in the U.S., and the vast majority of these women, like Fox, are survivors of violence. Studies have found that 90 to 99% of incarcerated women have experienced emotional, physical, or sexual abuse. And due to increases in the length of sentencing, as well as three strikes laws, the population of incarcerated women is growing older. By the year 2030, more than a third of people incarcerated in the United States will be over the age of 55. And it's also important to highlight that this doesn't affect all communities equally. Many are familiar with the statistic that 1 in 3 Black men will be imprisoned in their lifetime, and there's similar disparate impacts among women as well. So 1 in 18 Black women will be incarcerated compared to 1 in 56 women overall and 1 in 111 white women. So it's quite stark. And in fact, Black women have the highest conviction rates for life without the possibility of parole sentences, meaning they're even more likely to age behind bars. So I'm in California. Most of my research participants were incarcerated in California state prisons. And so just to give you a snapshot, this is from the California Department of Corrections. I would have done these racial categories differently and not just had another category, but I did just want to highlight that you can see that the population of Black women is about 25% compared to the state overall, where Black women are about 6%. And then I wanted to talk about age. So, as many might suspect, prisons tend to skew younger than our society overall. But in prison, when we talk about someone being an older adult, we really are talking about age 50. So, the number of incarcerated older adults is really growing, and it has the effect of aging is quite profound on the body. Compared to the general population, incarcerated persons are more likely to have high blood pressure, asthma, cancer, arthritis, and infectious disease. And research has shown that incarcerated women are more likely to have serious health problems than incarcerated men and seek healthcare in prison more than twice as often. For this project, I used Black feminist epistemological methodology, which is a qualitative methodology based in Black feminist theory with the aim of centering the voices of those affected by social problems and allowing engagement in the analytic process. So I spoke with 11 Black formerly incarcerated women who were all age 50 to 80 with an average age of 60. They've been incarcerated in jails, but mostly, or state prisons, but mostly in state prisons from anywhere from 6 months to 27 years, with most of the people I spoke with were incarcerated for decades. And on average, they've been released about 4.5 years. And all have some form of chronic illness, including heart disease, diabetes, chronic pain, or autoimmune disorders, and others. So I'm going to go through about four main themes, all related to if and how folks were able to access care on the inside. So I wanted to start with this idea of character. So one woman I spoke with, second chance, she told me that she was known inside as the church lady. She was very involved in her church. It sort of dominated her life, and the guards and other people who were incarcerated talked about her as the church lady. And because of this, she thought, the guards sort of knew her as what she said is one of the good ones. And she spoke of the importance of demonstrating character while in prison. And this was a common theme that many participants expressed. Women who are incarcerated have to first prove their humanity before they be provided sort of basic human decency, like access to healthcare when ill. Second Chance told me if you don't have that type of character in you to let them see, they're not going to show you any type of caring, any type of sympathy. They just don't feel like you deserve it. And this was echoed by other participants. If guards don't see you a certain way, you wouldn't be believed when you got sick. And some participants understood this. They noted that there's fakers. As one participant put it, people do pull shenanigans. People do fake illness. In some ways, it extends beyond just the initial need to prove your character. Even once you have established that, you still need to prove the severity of your illness to the medical system each time you need help, each time you get sick. So Second Chance was, this nice church lady. Fox, who was this leader in the community, they still suffered for many months or years before gaining access to specialists or to diagnostic because it wasn't believed that what they were experiencing was severe. And so, this idea of othering patients, assuming that they're drug seeking or have ulterior motives, also exists outside of prisons. But I think how it operates inside is quite stark. So this is an example. Someone says, I have so many horrible medical stories from that place. Even from a girl, her stomach, she was tiny. Her stomach blew up like a balloon. And they were kicking her, saying, get up, nothing's wrong. She died 2 hours later. Her appendix ruptured. She died 2 hours later. So this type of story haunts many of the women I spoke with. And like I said, I think it mirrors what we see in the community, especially with patients of color. You're assumed to be drug seeking, you have other ulterior motives, but it's more heightened in prison where, first of all, patients don't have the opportunity to go to a different ER. You can't find another source of care. And really that these individuals aren't always seen first and foremost as patients. So sort of universally, participants spoke of the need to do their own research, to be their own advocate, because they weren't always able to get in to see a provider. They weren't always able to make sure they got adequate health care. And there was this constant perception that they were not seen as patients, but as inmates. And indeed, that's how they're known on forms officially, right? You're listed as an inmate patient. The inmate comes first. And one participant described being taken for care at a hospital outside the prison. She said, you walk in there with shackles on, they're not looking at you. They're going to give you the minimum. You're not a priority at all. But most people describe the worst care as coming from within the prison when they're getting care there. One participant described the difficulty in even asking a question. She said, so they'll say things like, I'm not giving you medication. And somebody would be like, why? They push the button and an alarm goes off. She's disruptive. And then you get in trouble and escorted out. So these fairly mundane patient-provider interactions are operating under the shadow of this punitive system wherein you're an inmate first and a patient second. And what's striking to me about this is just the lack of autonomy that these participants express they have in their medical care. And there's quite a bit of negotiation and navigation that goes into figuring out ways to have autonomy within the patient-provider relationship and around decision-making. So even when folks are able to access care, if they have the social status, they're leaders, they're still not ultimately fully in control of their own care. So this comes up in a few ways. So first, as I mentioned, participants are not always able to ask questions. One participant told me the story of receiving the results of a mammogram back with a medical code and a notation that something was benign. And so she had some follow-up questions, and she told me, so I said, I want to ask you, ma'am, please, as a woman, can you please tell me what is this code and what is benign? And she said, it's of no consequence to you. It doesn't matter. And you need to leave before I push the alarm. And I'm like, wow, that's how things go in here. So not being allowed to get an answer to a question. And then, even when they can ask a question, the answer is unfortunately often no. Another participant told me about having a bad reaction to a medication. It was a blood pressure medication. She said it made her feel high. And she didn't have an option to take something else. So she ended up going without a medication. And someone else told me it's either that or nothing. I think you do have a choice. The other option is just no help at all. Another participant I asked if they about their choices just simply told me hell no, right? But this gets more complex then. What happens when someone does refuse care, if someone doesn't like the options presented to them? On face value, people who are incarcerated, like all of us, have a right to refuse care. But it's the way that that plays out in reality is more complex. So one woman, Isis, she told me a story related to this. She had an experience where she was sexually assaulted by a nurse in a skilled nursing facility in the prison. And for some time after that, she refused to go to medical. She didn't trust them. She was scared and didn't want to seek care. And she told me there was some retaliation. I was threatened if I didn't go to my medical appointments, and I became very fearful of going to medical. I didn't trust them. I didn't want to be there. I was threatened to get written up. I would get in trouble. I've gotten written up a few times for refusing to go. So yes, that was definitely a form of retaliation. And so I just want to, highlight the tremendous work that goes into navigating this terrain. So, noting all this, all that has to happen to be able to seek out care, participant told me that for a decade, she just didn't go to medical. And then when she finally did, she had to figure out how to get her needs met. And she told me it took me years to speak up for myself. And then I had to really I can't say over assertive, I had to find a balance between assertive and aggressive to get the help that I need. And many Black women are familiar with this negotiation in many arenas of our lives. So, there's a particular consequences to not sort of threading this needle. And I think, when walking the line between assertive and aggressive, the consequences in the prison health context are particularly stark. So another participant said, once they press the button, this is the button where they signal an alarm for a guard, once I press the button, you automatically get a disciplinary, disruptive inmate, disrespecting staff, refusing to direct order. So now I can potentially stay in prison 10 more years. And several people reported, they or a friend going before the parole board and it being indicated that they have anger management issues, aggression issues because of these types of interactions. And it can mean that they're not eligible to be released. But what's clear to me is even though the prison system attempts to take away autonomy and control, people who are incarcerated find ways to take care of themselves and others. And we know that as the prison population ages, sources of care become even more important. So for older adults in the community, we often talk about caregivers, and those become often for people inside other people who are incarcerated. They develop familial relationships to help provide care. So one woman told me of an experience when she couldn't complete her own activities of daily living. She said, when I had surgery, because I had my gallbladder removed, they let them come in my room. So they would bathe me and help me and take care of me. We had a family. But it's important to note that this isn't automatic. This participant said they let them come in. It's only possible if a correctional officer agrees. And as I noted, who's sick and who's not is not automatic. It's not always honored. Researchers describe many different prison activities of daily living, things like climbing on a top bunk, dropping to a floor for counts, standing in lines for meals or medication. And support for or being excused from those activities is something that people who are incarcerated must advocate for themselves and others. Finally, I just want to wrap up by talking about some of these implications of of this for people's health, both inside and outside. So first, I wanted to stress that because of this difficult navigation, care can become a paradox. So one participant told me, I'll be 65 in a couple months, and it's been hard. I think that I probably could be in better medical health if I trusted them, but I may be in better medical health because I didn't trust them. So it's a feeling of I maybe could be doing better if I had taken certain medications, done certain activities, gotten certain tests, but a real fear that their health would be worse off had they sought care. And this doesn't just stop at, when people leave prison. So even after people are outside, care may not always be fully utilized. So another participant said, I'm home now, and I still have these habits. I still don't go because for 27 years I created this habit and I don't have to because the place I work now pays 100% medical. They pay 100% dental and vision. But it's become a habit after 27 years of trying to save my life. And I'm still, right now, after 2 years of being here, trying to create better habits and to get out of my mind that I can't trust doctors. So Over the last year and over the last few months, as we've worked to distribute COVID-19 vaccine to the most vulnerable in our country, the topic of mistrust in the Black community has once again come to the forefront. And, I could easily spend an hour talking about my frustration with our overemphasis on things like the Tuskegee syphilis study or why we're fixating on vaccine hesitancy when we don't have full vaccine access. But suffice to say, I do think mistrust of medicine, science, and healthcare providers is a critical point of discussion and inquiry when discussing health in the Black community, perhaps especially in an aging population. So, from participation in clinical trials to advanced care planning and end of life decision making, healthcare related to aging is often based in a trusting patient provider relationship and a clear articulation of options and goals of care. If a patient or their loved one has spent years being told you cannot ask questions, you cannot make decisions, and you can be punished for refusing to access a certain type of care, why would or should we expect that the current model of medicine, with short appointment times, limited relationships with providers, insurance bureaucracies, would be able to fully meet their needs? So, as we're working to transform the care of an aging Black population, we must consider the implications of incarceration on the health of those aging behind and beyond the bars. Thank you so much.